اوكي بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وآله وصحبه وسلم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. Thank you everybody for attending our maybe third or fourth online academic activities in King Abdullah Medical Complex in Jeddah. Again, we are very sorry for this delay because of the technical error we had. I'm very happy that we have today with us also with Dr. Godal. We have Dr. Ayman Al-Sulaimani, who is a best friend of mine, and he was my mentor before. He's a consultant thoracic surgeon, one of the pioneers in the kingdom, and he will be sharing with us his opinion and experience. We are very happy to have him with us today. So to start with, so this lecture is going to be about 30 minutes. We are going to give some important points about putting or managing chest tubes. It will be very precise, hopefully. Then we were going to the second part as our usual theme for the academic activities. We are going to have the discussion. Then after that, we are going to have our usual MCQs and mock exam. Okay, so to start with, I have no conflict of interest. So basically, any chest tube for surgeons or even physicians, because as you know, emergency physicians and even intensivists are helping us to put chest tubes. Sometimes it might be like a little bit of difficulty of putting chest tube, but you have to always put a systematic way how are you going to drain the pleural cavity. And the most important thing, or the most trick that most of us might ignore, which is the pain control, please. So to start with, tube thoracostomy or chest tube itself, it's a surgical procedure that is used to drain whether air or effusion of its type, transudative, exudative, chyle, or blood from the pleural cavity. And as I told you, that pain control is very important measure. So to talk a little bit, this very simple diagram about the anatomy of the pleural cavity. You know, the pleural cavity is a potential space that is, you can see the cursor here. Yeah, okay. So you have here the parietal pleura, which envelop the chest wall from the inside, and you have the visceral pleura, okay, which lies on the lung itself and the mediastinum. And between them, there is the potential space, the pleural cavity, which secrete a few milliliters of pleural fluid, which is usually low of protein. Why low of protein? Because in the infectious processes, the protein concentration and the ratio will increase during the inflammatory process or infectious process in general. So this is the very basic information about the pleural cavity. As we have mentioned, it's a potential space. We have discussed all this. So in general indications for inserting a chest tube, these are the indications of parapneumonic effusions, which are effusions usually develop post-pneumonia. Simple, this is it's called like this. Otherwise, there is pneumothorax, whether spontaneous, traumatic, iatrogenic. Also, one of the indications is malignant effusion, chylothorax, and for sure, post-operatively. So the principle of the underwater seal itself, as you have if you see here, they have went into many evolutions by time. Okay, so this is the very simple underwater seal where you should simply the tubing that is coming from the patient, the silver chest tube that's coming from the patient, the connector of the tubing here should be under the water level itself, so it can trap any air from going back into the pleural cavity. Then after that, they have developed here the two-chamber system where they have added, excuse me, they have added the suction compartment, so it can help of maintaining the intrathoracic pressure into its normal levels, which is usually minus 20, which is actually less than the atmospheric pressure. Then they have developed the three bottle system here, as you have seen. They have just added the container itself or the collecting chamber. Okay, so it can collect the fluid that's coming from the patient or the blood that's coming from the patient pleural cavity, and regulated by, for the air, it is regulated by the underwater seal. Okay, and then you have the suction here. We are going to show you more pictures in real life. So the technique in general, because this might be a common OSCE station. You might have a patient with pneumothorax or whatever diagnosis. They will ask you just simply to put a chest tube. So you have to go systematically, as usual. You have to take an informed consent. I assume that everyone knows about it. Okay. The second most important thing that, and I'm using this regularly in my practice, and my residents know that you should give a systemic pain medication, even if you give a small amount. If we can talk about like 25 milligram pethidine or 1 milligram morphine, anything that just keep the patient calm. Okay, you have to take for sure your universal precautions. Patient positioning is very important, and the last important thing is the local anesthesia. Most of the practitioners, they don't give attention to local anesthesia. They're thinking just it is at the level of the skin itself, but no, it is more than this, and we will explain it in the using the upcoming diagrams. Okay, so this is basically this is the usual or the common position that which is the semi-sitting position that we are using it. We are keeping the patients in just to put the chest tube. Okay, and the other position is the lateral decubitus, which we usually use in case of thoracotomies intraoperatively. What I want to say, in thoracotomies, video-assisted thoracoscopic surgery. Okay, but this is the commonest position we usually do. Okay, so you have to prep and drape the patient very well after giving the systemic analgesia. Okay, the point is this is a very important picture. Okay, that shows you it's very important that you inject your local anesthetic through all layers from the pleura up to the skin. Okay, so you just start giving the local anesthetic in the skin, then you can advance it. Okay, until you feel the upper border of the rib that you are going to insert the chest tube in the correspondent space. So then the sign that will confirm that you are you have passed the parietal pleura itself, whether you are going to withdraw a blood or withdraw a turbulent fluid, or whether it's air. Okay, so you are just keeping on suctioning the syringe itself until you reach the pleural cavity. Okay, so once you got air or fluid inside your syringe, you just withdraw a little bit and you start injecting, because the parietal pleura is very sensitive to stretch. Okay, so inject all around up to the skin, then you give some time and start your procedure. Okay, so then after that, one of the important, you have to make sure that your dissection is going above the lower rib of the intercostal space that you are going to insert. Okay, so basically you will need to use this Kelly or any of the instruments that will help you just to introduce the chest tube inside, and it can help you also in pushing the lower rib downwards. Okay, so it can help you to increase the intercostal space, and it will be much more easier for you to introduce the chest tube. Okay, so basically after that, okay, you put the chest tube. Usually we put it upwards for pneumothorax. For pleural fluid, usually we put it against the diaphragm, okay, posteriorly and inferiorly, to drain any fluid that might be collecting here. So after that, you have to fix your tube. Sorry, I didn't have any illustration for this. Whether you can do a burst ring, okay, you can tie it on the chest tube, then you can put another suture to help you again whenever you are removing the chest tube, so it can close the skin after that when you are removing. One of the procedures that one of the techniques that I usually do for the burst ring, I usually use the burst string itself to hold the tube in place and to tie the skin after removing the tube. Sorry, I had a video before that I'm illustrating this, but I cannot find it. So just basically you are going to do your burst string around the chest tube, and then after that you are going to wrap the suture itself. Usually we use Ethibond number 2, so you wrap it around the chest tube, okay, until you are satisfied that you have wrapped the tube well with the suture itself, with the stitch. So after that, then you will do at the end one surgical knot. Then after that, you will do a semi locking of this knot. Okay, so I have to show you a video for that, but most of my residents know it. So basically, whenever you are going to remove the tube, you are going to untie this knot. Okay, then after that you can unwrap the stitch and remove the tube, and you can tie the skin easily. Okay, so after that is the most important thing. What should you do next? So you have different methods. This is the most common underwater seal system, 3-chamber system that we are using, and most of us know about it. Most recently, they are having this nice electronic machine that we are using actually in our hospital. We will give you more details about it in a while. And you have other methods like this, what we call the Heimlich valve. The Heimlich valve, it's actually a one-way valve that will just keep it one-way direction drainage, okay, from the pleural cavity into the bag or whatever you're connecting the Heimlich valve to. Okay, so we're coming to to our regular pleurovac we are using, or the 3-chamber system. Okay, basically you are having here, this is the underwater seal. So to start with, whenever you are preparing your patient to have a chest tube for drainage, okay, so you have to make sure that all are functioning well. So simply you will start by adding water here, okay, till the level of 2 centimeters, okay, which will correspond here to 0. This scale will help you again later on for diagnosing if there is any leak. This is the water chamber, okay, for the suction. So you can usually keep it on the 20 centimeter. Then after that, we connect the suction to the wall, or for the portable suction machine. The aim at the end that you start having bubbling here at the level of the 20. Okay, so this will indicate that you are having a proper intrathoracic pressure. This chamber is what we all know is the collecting chamber that also will be collecting the fluid that is coming out from the patient chest. This is another one. This is another pleurovac actually, which has a scaling button that which is shown here. Okay, this will help you a lot because you don't need to scale your suctioning on the wall or in the portable machine. So just you connect the suction and you would know well that the suctioning power is appropriate whenever you are having, this one is empty for the time being, whenever you're having a proper suction, so there will be an orange cube that will jump with the suction upwards here. So whenever you're seeing that means that you're having a proper suction. Then you can change your scale here from you have 10, 15, 20, it depends on whatever you want. Okay, so this is the topaz medalia that we are using commonly. So it is composed of, this is a canister, okay, with the tubing system that is usually connected here with the computerized machine here. So basically, you have first to calibrate the topaz or they call it also medalia before connecting it to the chest tube of the patient. Okay, so here, this is a basic illustration. You can have here, you here have the pressure that you want to put your patient on. Okay, and here the flow that indicates usually the air leak itself. Okay, it's very nice that you will have, if the patient is having a significant leak, it will jump up to 1,000, 2,000, and you can nicely see it with the diagram afterwards, okay, that if the patient, whether he's improving and he's having improvement of the air leak itself, okay. So it is very nice, the diagram. I don't think, no, this, you can also change by the buttons here. It's very simple. You can change the pressure, you can increase it, you can decrease it. Then it can help you to follow up the air leak in your patients in general. So this is a basic principle about this nice machine. Okay, so usually we remove chest tube width. The basic principle is when the lung is fully expanded by chest X-ray, okay, and there is no air leak. For me, and sometimes if the patient has significant leak and it reached, especially after decortication with parenchymal injuries, I can accept a leak in the topaz itself up to 50. We can remove the chest tube. And usually fluid drainage should be less than 100 to 200%, milliliter per 24 hour. And usually I remove it up to 300 or 350 ml if it is a clear fluid that has no pus, no blood, etc. So again, how to remove. This is another important trick for successful removal of chest tube, because sometimes you might ignore again the pain control for the patient. So simply whenever you are trying to remove the tube, okay, he will just leave his breath and you will hear that nice gush of air that is going inside the pleural cavity. So again, it's very important to give systemic pain control, even a smaller dose. You have to inject also local anesthetic. This is what I usually do, and it should be synchronized with the respiration. We have discussed this. For compressive dressings, nowadays, usually I use it for those with, we can have the opinion of our colleagues later on, for those patients with continuous air leak, and we're going to discuss this. So I just keep this for the skin to be kept open, so the patient will not develop pneumothorax. Again, I will just come to the point of, usually I don't clamp chest tubes, okay? But chest tube, clamping chest tube, the problem of clamping chest tube, or let's talk about the advantages first. Clamping chest tube will help you to detect if there is any progressive pneumothorax after, in case of you have to remove the tube. Its problem is, and I have seen it before and I'm teaching my resident That patient, if you are not keeping the patient under control, monitoring, okay, and the tube, and you haven't instructed to him that if he got developed any signs, symptoms and signs of tension pneumothorax, the patient might die without, just like this on his bed. Okay, nobody will know about it. But if you have a good system and you have a good monitoring and nurses that are taking care of their patient and you are around, okay, we can clamp the chest tube. This is my only problem with the clamping of chest tube. I will pass this because we are going to discuss more in the MCQs and in the discussion. So usually definition for prolonged air leak, when do we call it prolonged air leak? It varies. There is no clear definition about this. And most of the papers that the literature, they are mentioning of a prolonged air leak of more than 4 days. So those patients, especially in case of you are having a patient with pneumothorax, so you have to work him up. You have to do further investigation. You can do a high resolution CT scan to detect if there is any blips. And if it is post-operatively, we might think about bronchopleural fistula. I'm going to give some points about it next. So simply, if your patient's having prolonged air leak and he has a blip, okay, so simply you can just go and prepare him for thoracoscopic exploration. You can find the blip and tackle it, and you can do simply a pleurodesis. What is this? The bronchopleural fistula is usually it is a complication that comes after, usually most commonly, pneumonectomy, or even it can be after lobectomy. And usually those will have a disruption of the bronchial tree itself that is communicating with the pleural cavity, and it will keep on with significant air leak. So usually those patients, you can keep them on prolonged chest tube management. Maximum that we can use is up to 3 weeks. Then you have other options. You can discharge the patient with Heimlich valve that we have shown you a while ago, and it can be connected to a regular bag, okay, and patient can go home with it if he is clinically stable. Other methods that are used but with no clinical significance is that we can use autologous blood injection through the chest tube itself. So it's basically you withdraw 50 milliliter blood from the patient himself, then you can inject it through the chest tube, and you just can keep the tube of suction for a while until it goes. It's the principle of this is the same as the platelets, the coagulation method, that it will go and find any disrupted surface, like in the bronchial tree or the parenchyma, okay, and it can just simply go and plug that ulcer, what we can say, okay. So I don't have that much results of that. I have used it before, maybe in a couple of patients, but it didn't show any benefit. Surgical intervention is very detailed and complicated. I'm just, you can operate on the patient by posterolateral thoracotomy, and you can just go and find your leak from the bronchial tree. You can do debridement, you can do primary suturing, which is unlikely to hold by itself. You can use other methods like intercostal muscle flap, okay, in case of coexistent empyema. You can do other options like Claggett window, where you just keep it as an open, keep the intrathoracic space open to the atmosphere, and it will heal by itself by time. But it's very time consuming, and the patient will stay with you for a long time. For the persistent fluid output, also we'll come to the discussion, and it usually depends on the fluid analysis, whether it is exudate or transudate, and That time you will, it depends on that, whether if you are having a patient with empyema or if the patient is having pneumothorax. It depends. You will go and operate on him after doing mapping by CT scan with IV contrast to show you exactly if there is an empyema, to show you what stage of empyema is that, or whether there is loculations, whether there is the thick peel that prevents the lung from going back. If it is a clear exudate, sorry, if it is a clear transudate, okay, and there is no obvious reason, you can just go simply do thoracoscopic exploration. You can use the talc, or the stock in general. We can either do mechanical pleurodesis or we can do chemical pleurodesis. Okay, this is the most common. Mechanical pleurodesis I've discussed in pneumothorax, or you can do pleurectomy. You can just remove the pleura from the chest wall. So it will, the aim at the end, it will help you for, it will keep the lung attached with the suction attached to the chest wall, and it will cause adhesion, so there will be no more space to reaccumulate fluid inside. Okay. Other thing, we use the talc. This is sample of or an example of the talc we are using. Usually we use the talc for those patients with advanced or metastatic disease with malignant pleural effusion, and those who are elderly. We don't use it usually. We don't use it usually for young patients with pneumothorax or pleural effusion, etc., because you might need to operate on him later on, because the talc itself, it causes sarcoma. It will significantly cause adhesion. It might be difficult to reoperate the patient later on. Okay, so this is the picture. The nice thing of this long catheter, that you can widely spread the talc itself inside the pleural cavity on the surface of the visceral pleura, parietal pleura. Okay, so this is the general picture that you are going to find at the end of your pleurodesis. Okay, so in the first 2 hours, usually we don't put the patient on suction, just for the talc to take to be adherent to the surfaces. And after that, we can put the suction for the lung to keep on expansion and to cause adhesions between the parietal and visceral pleura. This is another method, but it's not our talk today. This is a Pleurix catheter that you can use for those patients with chronic pleural effusions. So it can help you to discharge the patient, and it has also a one-way valve. It's the same principle as the Heimlich valve. Okay, so just a few. I'm thinking I'm about to finish now. So just they were talking a lot, as we are now currently in the era of COVID-19. There are some recommendations from the British Medical Journal and a lot of societies. But I found this was one of the famous or most spreading opinion from our colleague Dr. Faranaz. It was actually posted in LinkedIn. Just the idea of this is to protect the healthcare professionals during putting a chest tube from any expert or any contamination from the pleural contents during putting the chest tube. So what she had mentioned in this, I'm not aware if there are prospective studies that have done about this. So simply she mentioned that it's better to disconnect the ventilator from the endotracheal tube, while just at the step of piercing the pleura. Okay, so you will prepare the patient and do all your steps you're doing for an chest tube. You will just put your local, start your incision until you reach the pleura. Okay, before piercing the pleura, just you ask to disconnect the ventilator. In my opinion, I think we can do other methods. Some of my colleagues mentioned that we can clamp the endotracheal tube, but for me, as long as you will be rapid and efficient, you can just simply put the ventilator on apnea mode, okay, while piercing the pleura. So you just don't need, so it's the same principle. You can put the patient on apnea, then you can pierce the pleural cavity and you put your tube. Okay, then after that you continue your ventilation. Okay, so we'll go through questions in a while. So I think it's been a little bit long. So my take-home message: chest tube insertion. It could be a very simple procedure for you, and you have to take all. You have to put your protocol always to put this chest tube. And the most important thing, you have for sure different methods to connect the to connect your chest tubes in, like the Pleurovac itself, single or water seal chamber. It was an old school, and the any other electronic devices like the Medilia Topaz we are using. But the most important thing, that important issue that I want you all to put in mind: please control the pain, control the pain, control the pain. Thank you very much.